Sorry, that was a brief call which I could not avoid.
Of course.
So, where are you at work? Are you at home or?
No, this week I've had a couple of days off, and today is actually one of those days where I'm working from home, so I don't really have a day off. I've spent most of the day in various different meetings, so and none of them academic. So I'm looking forward to some actual academia for a
So,
pleasant change.
so let's bring in Mohammed Nasif. Mohammed, tell us something about yourself.
Welcome, Mohammed.
Yeah, can you hear me? Yeah, go ahead, Mohammed. Just tell us something about yourself.
Good evening, Arun sir. So I'll just introduce myself. I am Mohammed Nasif. I am from Palakkad district. So I had done my UG. It's very nice. That is already seen it. So I had done my UG in Nice College, Bangalore University, and my PG in Nita University, Bangalore. So it's been 1 year since I started my vestibular clinical practice. So in Apple Medical Center, Anarkad, it's in Palakkad district only. So why I should take this opportunity means even I want to make sure whether what my findings is correct or not, whether my diagnosis is as much accurate. That's why I took this opportunity. So this multiple canal is very I felt too difficult to diagnose. So that's why I put this case. It is a multiple canal, sir. I don't think it's a
No, so we'll come to the case formally. Wait. Right now, I was asking about yourself.
yes, yes,
So,
sir.
in the place that you practice, by the way, Arun, this is in Kerala, the
Yes.
the Sylvan surroundings which you visited last time.
Oh, okay.
So,
Lovely.
Mohammed, tell us something about your place of practice. What kind of patients do you get, and how how
So
how
our
are you equipped?
resources, yeah, sir, our resources are very limited. So
Okay.
the resources are very limited, but the case exposure is quite high. So mostly we are seeing BPPV, severe migraine. So recently I have dealt with a brain concussion case, but I didn't get any findings in VNG. But the with history, sir, with history I have came to
Diagnosis.
conclusion about the concussion.
Very
Most
good. Very good. So, Arun, can we start? We have
Of course.
about 17 people who have checked in. I think they will come as they go on. So
Mm.
why don't you start, Mohammed? You can be cool. This is not a formal presentation. This is discussing the case, and
yes,
you
yes,
know,
sir, yes, sir,
Yeah.
yes, sir.
Dr.
And
Like
let's
I
be honest, we might all
like I
not
told,
all know the answers. We'll discuss it and we'll
yeah,
learn all from it together.
like I told,
Yeah,
just I want to make sure whether my
no,
sites
that's
are correct or not. That's it.
we just present the case as it comes. And if you don't mind, I'll interrupt and we'll discuss in between as we go along. Go on.
Oh, okay. So the
Yeah, go on.
PPT,
Uh, you Vishnu, can you play the PPT?
Yeah, sure, sure.
Yeah. Go ahead. The floor is yours, Mohammed. Please.
okay. So hi, good evening all. So we just started discuss the case of multiple canal BPPV. So as we all know, the most common type is posterior canal followed by horizontal and anterior canal. So I'll just start with a brief introduction about BPPV. So it's nothing but benign paroxysmal positional vertigo. So I hope everyone can see those are the three canals, anterior, posterior, horizontal. So you can see the black spots, that is nothing but the calcium carbon crystals, so which can found in the top of the macula. So it will get dislodged from there and enters into the semicircular canal. So that second picture. So in short, it's nothing but a presence of autogony in the canal. So that is BPPV. So the canal becomes gravity dependent and the patient will feel sense of acute vertigo, the severe vertigo in the acute stage. Next. So it can either be age-induced or after a fall, after a menopause, migraine, high blood pressure, high cholesterol levels, ear surgeries, other diseases affecting the inner ear. So the 83, according to studies, 83% of are idiopathic. There is no cause. Without any cause, it can dislodge from there. And the most ratio is there in females when compared to male, 3:1.
Okay, so here I just interrupt for a minute and toss a question to Dr. Arun. He raises a good question of ear surgeries which should be causing risk for BPPV. Now, though we use high velocity drills when we do ear surgeries, 40,000 RPM and so on, I don't recall too many BPPVs post ear surgery. What is your experience, Arun?
No, I agree. I don't think it's, whilst it is technically a risk factor, the actual numbers we see are relatively limited and actually tends to be for more traumatic invasive surgery. Now, it may not be immediately post ear surgery as well. So some patients we see several years down the line, having had a history of ear surgery, so that ear has always been slightly weaker. Is that the surgery or is that the underlying pathology? I think that's the chicken and egg question. Because obviously we're talking, is it a weaker ear? And if it's a weaker ear for whatever reason, then you're more likely to develop BPP in that ear.
No, because this is surprising because
Yeah.
shock head injuries even without a temporal bone fracture. Hello, can you please mute? Yeah, head injuries even without a traumatic fracture of the temporal bone leads to
Right.
BPPVs. But ear surgeries somehow don't seem to. In my experience, I can't recall anything which is directly linked. That's why I pushed that
I've
question.
seen very, very rarely it's been very immediately after the surgery, maybe a few years down the line, but that could be a multiple different factors. And on the sort of, I guess, etiological risk factors, we see a lot of patients in the UK and I guess in the Western world with low vitamin D levels. That's a significant risk factor. And of course, we were talking about sunshine earlier. That's our limiting factor. How is that in sort of the Indian population? Is that something someone has studied? Because of course, sun is plentiful there.
Yeah, but nowadays, I don't know, it's become a fashion to check vitamin D, and almost everybody has a vitamin D deficiency.
Oh, interesting. Okay, so
But
even in India, even in
yeah,
India
and I'm not talking about BPPV patients in general.
in general, is that because of any particular reason that they're low in India, particularly
My,
because that comes as a surprise, of course.
if I may be permitted an aside, I think it's because they have tweaked the machine parameters. So,
Yeah, fair enough. Okay.
okay, go on, Mohammed, please. I hope you don't mind us taking the discussion
No,
like
sir, no,
this.
sir,
It's
no
okay.
issues, no
Okay,
issues,
go on.
no issues.
Go on, go on.
Vishnu, can you change the slide?
Vishnu, you should change the slide. Go on. Yeah, go on.
So as I told before, the ratio is more in female. So our patient is also a 46-year-old female. So came to a department with a 2-day history of positional vertigo accompanied by lightheadedness, nausea, and unsteadiness. The symptoms were triggered by specific movements, so such as lying down or looking up. I have missed that, and or transitioning to lateral positions on either side. No, next slide. So she didn't have any oral complaints, no hearing loss, no tinnitus, no earblock sensation, no other histories, but she's taking tablets for taking medication for hypertension. She's very tensed person, as reported by her husband.
Go on, Vishnu. Change slides when he says so. Yeah.
So we have started our evaluation. So we just begin with our subjective assessment. So Romberg finger to nose test, Fukuda stepping test. I didn't find any significant findings. So we are next.
Can I interrupt them? So is that Romberg on a hard surface, or do you have like a cushion or
With
anything
or
like that?
without surface, with and without surface, sir.
It's on hard surface. You said, sorry.
Yes,
Yep.
sir.
He
I
said
have
with and without, both.
with and without, sir.
Okay. So you have the cushion of some sort to be able to assess them with and without visual input. Okay, perfect, perfect. Because of course, if it's just hard surface, it'll be more a test of proprioception. And I always do strongly recommend instead use the soft cushion. Then you have a real feel of whether it's more vestibular or not as you're removing. Perfect. Thank you. Sorry, continue.
Vishnu, next slide. So we didn't go for the full ENG evaluation. We just start from our, as our doctor suggested, we just start from questionnaire test. So we got findings in roll right and pitch backward, which is responsible for the posterior and lateral canal. No, next. So we start from Dixol peg right. So here, actually, I tried to add the videos, but I couldn't able to add. So I have, instead of that, I have added gaps. So in Dixol peg right, supine, when I moved to supine head extension towards to right, uh, I observed a torsional upbeating towards to left beating nystagmus. So there will be a delay in latency I have observed.
Go on.
When I made towards to next shift, sit at right, there's a torsional downbeating. It's not much significant, but the torsional downbeat towards to left side.
Can we clarify this here, actually? Just go, I see what you mean when you're observing the traces, that it's kind of pointing leftward, and there's probably some upbeat components as well. Now, with a whole pike, like a traditional whole pike, and you get BPPV, the way I describe it is this torsional component going towards the downmost ear, which will be, in this case, if you're doing the right side, towards the right ear. So it'll be torsional to the right. But on a couple of occasions, you mentioned sort of left. Is it because it was going to the opposite side? Or was it actually sort of going torsional towards the right downmost ear?
So,
because I know the tracing is always difficult. I mean, it's so I just wanted to clarify that.
So what I have learned in Dixol peg right means during the supine at extension right, we'll get a
like that, all the way back.
Torsional beat towards to, and right, torsional beat towards to left side. When mirror sit, there will be a torsional downbeating.
Okay, fine. So just to clarify, it'll be, so you're putting your head back, you're turning your head, you're lying the patient down at an angle, and their eyes are going towards the right, towards down, towards the right side.
It's down beating basically.
It's down beating towards the right side, because I know the up beating and down beating, so many people use different terminologies. That I like the torsional component. Don't get me wrong; that's very clear, and I think that's where the latency is also something which I think it's very nice to describe. But again, it'll be when it's turning, it's like going up and downwards, like in the posterior canal BPPV. Is that correct? Is that what you mean?
No, sir. What I meant is, as I said before, when we measure into the supine head extension towards to right, we'll get a torsional upbeating towards to opposite side.
Opposite side. Okay, fine.
Opposite.
So you did mean opposite side. Okay, fine. Yes, so that was very atypical, basically.
So then we'll made her to sit head towards to right side. We'll get the downbeating, torsional downbeating.
Fine. Okay. So it is going the contralateral opposite direction than you're expecting it to. Is that correct? Perfect. Okay. Okay.
So next slide. Then we started. Then the Dixol peg left. So when sit head left, we didn't get any torsional components. So it's more like a right beating nystagmus. Vishnu. Then during the next shift, we get a mixed of, so more according to the stoppage velocity is the more like a torsional upbeating. So torsional upbeating towards to right side in when Dixol peg left. Then the last shift, as like same before, we got no vertical components. It's more like a right beating nystagmus. So then we have assessed the for lateral canal Paganini. So during the situ supine, we have observed the left beating nystagmus.
So just one clarification. You do all the positional tests, or if you find something in the posterior canal, you would treat it first. What would you do?
No, sir. We have done all the testing. Afterwards, we have done the correction manuals.
Okay, so you went ahead for the Paganini immediately after the Dix-Hallpike.
Yes,
Right?
sir. Yes, sir.
Okay.
So in between, she had complained. She had the vomiting sensation because she's acute.
Yeah. So just stop here, and Arun, what do you do if you find something very distinctive? Do you attempt to close it, or do you run the entire cycle?
I generally speaking, I tend to close it straight away, only because if it's very clear-cut positional nystagmus, which is typical of, let's say, posterior canal BPPV, then yes. But if there are any atypical features, and I think, and this is what I wanted to clarify initially, if there are atypical features, then I will do the whole, all directions with the video frenzels to be able to then determine or at least localize the site of the lesion a bit more. And just to clarify, and again, just going back to the earlier question, Mohammed, you mentioned it was very atypical, isn't it? Like the nystagmus on the whole pike. On the left side, you got right beating. On the right side, you got left beating. So it was very sort of atypical. So in this case, I would have probably proceeded on to do the horizontal and even resting nystagmus and everything else just to get a bit more of an understanding. But if it's very clear cut, then that's the first thing I treat. And sometimes even that I mitigate if I even think they have posterior canal BPPV, just for the sake of at least getting more information and understanding the anatomy, etc. I do sometimes do the Pagini first, and then go on to do the whole pike, knowing full well that I'll expect some results in the whole pike. But that's, as I said, if you wanted to really explore the characteristics. But anyway, I'll let you continue with the.
Okay. Vishnu, next slide. Then we move to the right lateral position. So we'll get there were actually no latency. So when I murder into change into right position, the nystagmus was very quite high. So as you can see, slow phase velocity was a left beating nystagmus we got. So also we have found some downbeating nystagmus, but I in video I didn't find any downbeating components. Would be something about our Googles, alignment of Googles. So so anyway, it's a red flag when you get a downbeating nystagmus in vertical. So
Go on.
next slide. Then we made it into supine head neutral. So we found a left beating nystagmus, supine head neutral. So when in the right position, it was more like the nystagmus was like a more high. So actually I have done very fast. So that was my mistake. Then I made it into after 50 seconds, I made it into supine head neutral. That time I have seen that crescendo decrescendo pattern. Then I have made a move into left lateral position. So that time we got a right beating nystagmus, which is less compared to right. It's a cupula lithiasis. So when to supine head neutral, we found a right beating nystagmus. During the sitting position, there were no findings. When I made into deep head hanging, I found a left beating nystagmus. So it is not much quite high when compared to other Paganini disorder. It's a very like a small beating towards the left.
Okay, so could you just sort of summarize your findings so that you know?
So what I believe is it's a right side. In the disorder, I have the more intense in right side than the right canal lithiasis. And when it comes to
Don't go to diagnosis. Can you just summarize your
so I found
DHG
more intense in right side in disorder, and in Paganini, I had to diagnose. It's like a more intense in right side. So when it comes to cupula lithiasis, we'll take the healthy side for the correction manual.
No, come again. right side, you found evidence of nystagmus towards the right side or evidence of pathology on the right side. Could you just clarify that?
Sir, I don't get you, sir.
No. Could you just summarize the VNG findings on one hand and then come to your diagnosis? That's my request.
Okay, sir. So from the beginning, so we get roll right, we get a positive response, and pitch backward, we get a positive response. So it will be responsible for the, as I in the beginning I said before, the lateral canal and the posterior canal.
No, don't go to diagnosis. I want to hold you back on that.
Okay.
When you
So,
did, VNG,
okay.
you found what? Just tell one by one. This test you got something. This test you got something.
Yeah.
Then we can put it together.
So roll right, pitch backward, we got positive response, and the right side also we got a torsional response. When it comes to left side, this will take the torsion component is less, more like a horizontal nystagmus. And in the macular paganini, the right lateral, the nystagmus was very quite high, and the left, when compared to right, it is less. The slope is velocity.
Okay,
Then we have
go on. Go on.
Then we have done the supine head neutral, which is for the anterior canal. Then it was during the sitting position, there were no findings. When I have done the deep head hanging test, the left beating nystagmus was not quite high when compared to other necropynia and mixolpike. So, the findings, sir.
So basically now you have a smorgasbord of findings. So Arun, this is his problem. He has some findings on the right, some findings on the left, and though his symptoms suggest more on the right, when he did a head hanging, he seemed to have problems which suggested on the left. So I think that's his problem.
Oh, well, if you permit me, Dr. Nair, I'll take a step back to a certain extent, maybe in the interest for everyone who's listening. And then, obviously, all of the findings you're describing are typically what we call, red flags. They're not ones which are straightforward. They're not clear, typical, one-sided BPPV type of nystagmus. So when we think about red flags, we're always thinking, well, is it just BPPV? Is it something else? Can it be vestibular migraine? Can it be a stroke? Can it be a tumor? It's a relatively acute, and this is where the history then comes in as well. So it's a relatively acute onset scenario, isn't it? It's 2 days history, you said.
Yeah, yes, yes.
And it's positional dizziness, so it's head movement related. But again,
Yes,
it's not just not like lying in bed. It's also when you're moving your head generally as well. And then tell me about her balance wasn't too bad in the testing that you did. So that was actually pretty good. That's reassuring. So that makes things like central acute strokes less likely. So I think we should consider that in the grand scheme of things. But at the same time, you also mentioned in the history she has some imbalance. Is that correct?
History, no, sir. And unsteadiness, yes, unsteadiness.
Just unsteadiness, but more the main symptom is head motion or head movement related dizziness. Fine. And now if we go on to this, and that'd be nice to, it would be nice to see some videos, of course, but in the absence of that, it would have been nice to have a table of all the individual findings. And if we then summarize the findings that I've seen so far, and correct me if I'm wrong, the most strongest nystagmus we had was on the horizontal plane with the macular Paganini test. And that was the strongest nystagmus. And the way I would describe it is because it's going away from the ear turned into it. So it's apogeotropic nystagmus. Is that correct?
Yes, sir. Yes, sir.
And which one would you say is stronger, the right or the left apogeotropic? Because I thought, well, mind you, we can go back and have a look, but which one was stronger in this case? Is it right or left side?
So you're asking about macular Paganini?
Yes, correct.
It's a cupula case, sir. So as I said,
no. He's asking in which way nystagmus more.
The more strongest nystagmus is right side only, sir.
Right side, okay. So right side, which then points in the apogeotropic nystagmus, it will point towards the left side horizontal canal pathology, a left-sided, a cupular lithiasis as opposed to a canalio lithiasis. So that's number one. Number two, there's also findings on the Dix hole pike maneuver, but they're very atypical findings. They are going to the opposite direction. So you can almost say, is that an extension of what you're seeing in the horizontal canal rather than multi-canal? Because there is some torsional components, yes, and the torsional component is only present on the right side, but it's still apogeotropic, isn't it, when you go down? It is still beating away from the downmost ear.
That is, when you turn the head to the left, which way is the nystagmus pointing? Mohammed?
So, sir, actually, I have done a course, sir, from I have taken a hands-on training from Aish. So
just describe the nystagmus. Leave the
Okay,
training.
just description.
When
But,
you
sir,
turn when you turn the head to the left,
oh,
what direction was the nystagmus pointing?
in which
On
test,
the whole,
Eh,
this will pay.
Both the hall pike and the McClure.
Yeah, sir, that's what I'm telling, sir. So what I have learned, so during that hands-on training, so they have told when it comes to right posterior, we see the left torsional.
No, what did you see? I agree with what you learned, but what did you see was the question. In this case, yeah, what happened?
Okay.
Tell
Right
that.
side, we get the torsional a bit towards to left side.
Okay, and McClure?
About right to left, sir. Right side we get a apogeotic, sir. Right side, it's a left beating nystagmus.
Okay, fair enough. So that's what you were saying, Arun.
yes, correct. Yes, it's always going towards the left in both, and in fact, the stronger nystagmus was in the horizontal plane, and then the left. Now, if we describe the same way to the left side, when you went down left on Dix hole pike, which side was the nystagmus?
Right beating, sir.
Right beating. And similarly, when you roll your head to the left on the Pagnini McClure, it was
Left side.
again, it was right sided, wasn't it? So each side, when you turn your head, it's beating towards the opposite direction, whichever test you're doing.
Is that correct, Mohammed?
Yes, sir.
Yeah. Okay, go on.
Okay. So on that front, well, we'll listen to Mohammed as to what he did, and then maybe we can go on to the discussion, because that way we've now described it nicely. We know what's going on in each of the different ones. Just to clarify, Mohammed, in the whole pike, in the Dix whole pike, which one had the nice torsional component?
Right side, sir. Right side.
The right side. Right side had torsional nystagmus.
Left side's more like a horizontal, sir.
Fine, perfect. Okay, well let's talk through your next slides, and then we can come back, because that's now clear.
So what my diagnosis is, like I said, right canalolithiasis and left epiphyseal. So I had taken the healthy side in the McClure Paganini. So I had done the Epley maneuver for the right side. Then in between she had the vomiting. So it took so many time. So after Epley, she had told me that lightheadedness, she got a slight relief. Not slight, better relief after the correction maneuver. So then we have done the Appiani maneuver for the left side. Then we have done the Buffoni maneuver for the left side. So the post minor precautions we have given, like additionally, we told her to follow some precautions. So for the first 30 minutes is crucial. So we told her to minimize head movements, and for 1 week avoid unnecessary head movements or bending forward or making sudden transitions, lifting weights, or avoid some excessive physical or mental strain. Also from our ENT, so Dr. Ranjit sir, he have given some medications also. So we told her to follow up after 1 week. So she came. So that time the nystagmus was very less, sir. When without BNG I have done the testing, Dixolpic and metrolpagini. It was very 5 seconds, sir. I have observed the nystagmus. So that time I had done the right Epley and barbecue roll for the left side, sir. She was like perfectly all right. So that's what.
Okay. So just to summarize, so what were the maneuvers you did?
So, like I said, the distal pike right is the most intense here. So we have done the right epli for that
Okay.
side. So after few
Okay.
minutes, we have done the what I believe is a cupula iliathesis, left healthy side I have taken. So I have done the left Appiani maneuver to her. After that, I have went for the Buffoni maneuver.
Okay. Why the two? What is the logic?
Sir.
After the Appiani, why did you do the Gufoni?
So that's I have a doubt, sir. Even I have doubt. So even I have asked my ENT, can we able to do like that, or can we able to give us some days of doing like that?
So
So
to
I have
just
some other colleagues also.
pull you back. No. So your functional diagnosis was what was your functional diagnosis? Can you just share it?
It's a multiple canal BPV. It's a combination
Which
of
canals?
right posterior and left apogеotropic horizontal canal.
Okay, so you conjecture right posterior with left. So Arun, the
Left.
question to you: can these findings be explained entirely on the right side alone?
I think I actually agree with the left-sided cupular lithiasis. I think that's the strongest nystagmus that we're seeing there, number one. Number two, the right-sided posterior canal is a maybe. It's a maybe because yes, there are torsional components, but the way, at least, so this is where the video would have been ideal, but the way it was described, I wouldn't have immediately thought right-sided posterior canal. It could be that when you're doing the whole pike, you're still stimulating the horizontal canals, which is why you're getting nystagmus on both the whole pike and the horizontal rolling. The Pagnini Puglu or the Pagnini McClure. I prefer calling it the horizontal roll. Just it rolls off easier on the tongue. But anyway,
And
the
he's
fact,
European. And he's
yeah,
European, not British. I know that.
Sir,
but
additionally,
ultimately,
Sorry, go on. Go on.
no. I was going to say, I was going to ask, Mohammed, when did you? So you these various maneuvers. Did you do it all on the same sitting, or did you do it one after another? And have you seen the patient afterwards?
yes, like I said, after the EPLI, so she had vomited, and after the
Okay.
EPLI maneuver, she got some relief, sir, from the lightheadedness. So she was
Okay.
better after the vomiting also.
So you did that first, is it, in clinic, the Epley?
Yes, EPLI.
Okay, and then you did the Appiani and the Gaffoni straight away, or did you wait until next time?
For 5 minutes, sir, because we have other patients
Okay,
also.
fine.
So we have
Fine,
5 minutes.
I understand. Fair enough. So you waited 5. So basically, you did all 3 maneuvers on the same sitting.
Yes, sir.
And have you had the chance to follow up the patient at all?
Follow. Sir?
To see the patient again?
Did the patient come for follow-up?
Yeah, after 1 week she came. So in between, we got a red flag, no, sir, that downbeating nystagmus. So we have also sent it for MRI.
Fine.
So
Okay.
we can make sure, even according to studies, 12% of population have the nystagmus, positional.
But
So
how was she when she came back?
That's the most important. Okay, sir. She's perfectly okay. That's right.
That's the most important question, isn't it?
Yes, sir.
Because that
okay.
is, yeah. Fine. And in which case, as I was going back to that one step previously, do I agree with the lateral horizontal canal BPPV affecting the left side? I think yes, because that's the strongest, nystagmus that you've seen. So it makes sense that you did the appropriate repositioning maneuver for that. And in fact, that could have been the curative one. And in fact, very recently, I saw 2 perfect examples. And sometimes, just bearing in mind, when you repeat that, they can canal convert from the lateral canal to the posterior canal. So always when you see them again, make sure you do the repeat Dix Hall Pike and all the positional testing. But going back to the right side, posterior canal, I'm still on 2 minds about it, I'll be frank, because of the fact it's not clear cut as far as I'm concerned. It's also on the contralateral side, which is not impossible, but it happens more if they have a history of head injury rather than suddenly all at the same time. If they have a history of head injury, then any combination can occur in any number of ears. It doesn't matter. But suddenly, why would it occur in the contralateral ear? Why? So if I'm thinking more left, is it just the left side is the left horizontal one? It's stimulating both sides, and hence you're getting nystagmus on both the whole pike and the horizontal roll. With regards to the treatment maneuver, as I said, I'm happy with that. The only thing I was going to comment was the post maneuver restrictions. We certainly don't do that anymore at all. So number one, we kind of tell them crack on, but don't go around doing anything super active. Let's say they're a professional sportsman, take a couple of days off, but do everything normal. I'm not against the idea of giving them some medical relief with medications. I think that's a good idea. And in fact, the final question I was going to answer was the downbeat. For me, I see so much downbeat that that very rarely do I find anything on an MRI scan. I would still do what you're doing, but all of the other features are more red flags. Let's say lack of latency and atypical nystagmus. All of those other features are certainly worthwhile MRIing or considering an MRI scan for. Now, with regards to as I said, the proof is in the pudding, is that what happened is that she's better and you did the right maneuver, you treated the left horizontal canal. Interestingly, the only other thing I was going to mention was the fact that with other conditions that can have atypical nystagmus, remember vestibular migraine. Was she a migraine person at all? Does she have any history of migraine? She's certainly the right age group to develop vestibular migraine, and that presents with all sorts of wonderful nystagmus. So I don't know if there was any factors.
Did she have any headache, Mohammed?
No, sir. No, sir.
No headache.
Nothing at all. No history of
Hypertension.
migraine.
Any history of migraine in the
No,
past?
sir. No, sir. Not as reported.
So here's a question for you, Arun. If you suspect multi-canal, do you have any particular sequence of maneuvers? Do you have any particular temporal duration between maneuvers?
Of course. I'll answer this the backward way because someone recently, I think, wrote a new maneuver where they called it the universal repositioning maneuver. I'll be honest with you, I've never tried it and I don't want to try it necessarily because just because it's new and written about doesn't always necessarily mean it's above and beyond the tried and tested. But with regards to treatment sequence, I'd always go for the strongest nystagmus and the most, and usually it's correlated with the most symptoms. So in this case, which is why I was going back to that horizontal over and over again, because that was by and large the strongest. And I think when Mohammed described it, it certainly was the patient was symptomatic there as well, a lot more. So I would go for the most symptomatic and the strongest nystagmus side first. And then, yes, I don't tend to treat multi-canal BPPV in the same setting because immediately they do get some relief, but I try and see them early so that maybe in a few days' time to reassess and then to treat the, let's say, other canals. But I generally do one canal at a time rather than all at the same time. And I'll try and space it apart by a few days. Hopefully that answers your question, Dr. Nat.
Yeah, so Mohammed, here's my question to you. You heard the British protocol, which is stagger the procedures. I assume that in AIC, in your institute in Mangalore, you learned to put them all together due to pressures of time. I don't know what.
No, sir.
No,
We
I'm not.
have
I'm just saying there are various ways of skinning a cat, so there's no problem. You can tell us what you do or what you were taught is also all right.
say, during my MSc in clinics, they have to do everything very fastly. Don't waste time. Everything will be done spontaneously. So if we wasting too much time in one patient, for example, PT, so they'll come and the supervisors will come and scold us. Why you're taking this much time? What to do?
This is assembly line vestibular treatment, but okay, fair enough. That's the way you have to treat. But I mean, I would tend to agree with Arun that it might be better to stagger. You can just give an appointment for the patient to come again.
Yes. Yes.
because you're safer. You're far safer. If you mix them up, you might land up with a third canal involved. That's my
Sure.
suspicion.
Sure. Sure.
So
Sure.
if you do one and you immediately spin into another, number one, the patient gets no refractory period to settle down. The autoconia itself don't get time to settle down. So that's the risk you run. And I suppose when you get into private practice, you might find it is safer for the patient, safer for you, and more remunerative for you if you call them multiple times.
Yes.
You can charge them twice if nothing else. So
Actually, that locality is very, the patients are very poor, sir. So we are for the BNG
no,
also
but
we
but
are.
no, but all the no that apart, I'm just all the more reason why you should be cautious in doing too fast things, because if you do it too fast, basically he wants symptom relief,
Uh, Actually, in the
irrespective.
beginning, I used to follow like that only. So for the upper GOT, first I have done the, for example, appeal I will do. So for the Gufoni, I tell them we'll do the next time. Then I ask my
And they won't
colleagues.
come back.
No, so I asked my colleagues what you will do for this type of situation. So they told will give them for a few minutes, then we'll do the another maneuver. It's
So
fine.
which actually now I pass the ball back to Arun. Is it worth considering this as a protocol change? That is, don't call them on another day. Considering, I suppose, the other factor in India is travel to break your, you don't earn when you travel to go to the doctor, and it's not under national health services or anything. Does it make sense to try to do it in one shot? Maybe you could
I
take
still would
more than
be,
five.
I would still be cautious only because we don't know what we're treating and you don't know what's causing relief. And number two, you don't know, and I think the more important part, as you rightly mentioned, Dr. Nair, was the fact that you don't really know where it's going to end up at the end. You might end up with a different canal involvement. You might end up displacing from one canal to the other canal, making things a lot worse. And then we start the entire diagnostic process again. So actually, for the sake of one follow-up, and I appreciate even if it's a quick appointment, listen, they can always cancel it if they don't, if they're feeling 100% better. But pick the strongest one, pick the most symptomatic side, pick the most likely diagnosis, as you were on the right, I guess, ball play anyway. You were on the right diagnosis. Make sure you treat it. Offer them a follow up. If they're better, you can always tell them, well, you don't necessarily have to come and see me. If you're not better, then yes, let's explore the other canals a bit more.
Enough.
But
And have you
sometimes things can self-resolve as well. Remember, BPPV can often self-resolve after you treat the most symptomatic side, as patients are moving around a lot more. That's the other thing to remember. So I appreciate there's lots of pressures.
But I'm also a little suspicious when we do this work. There are a lot of people who come by bus, and when I have sat in a bus of late, I've been shocked by the amount of jolts which you get, whether you're actually undergoing maneuvers while you're traveling by bus. What do you think, Mohammed?
So that's what I will ask the patients after the maneuver how you came. So they'll tell me by bus. We came by bus. So that's the anyway. I tell them you control your head movements. So that's the important part.
So here's just an open thought, Arun. What do you think? You think you should prescribe a cervical collar after this?
No, definitely not. So I think as far as we're concerned, we've stopped doing post-maneuver restrictions for the last 10 plus years. Used to be in fashion, but after that, we don't prescribe anything like that at all. Normal activities, nothing too active, but everyday activity is absolutely fine. And I do find that actually the more you move, that is almost a natural treatment in itself. So sometimes posterior canal BP can take a couple of days for it to resolve after the treatment maneuver. So it's almost like I'm helping it to then subsequently resolve on its own.
So immediate post maneuver, what do you have any protocol?
Nothing. Zero. Go home, enjoy life. Don't play football.
Okay. Another question which I would ask before I'll try to get the audience in after this, but just a question: in your practice, how often do you get multi-canal involvement?
Post head injury, I tend to see it lot more. Occasionally, it creeps up once in a while. But when I see multi-canal, as I said, post head injury is the most common by far and large of our patients. And occasionally with canal conversion, it can occur. So if you haven't done if it's on the same side, let's say you can get posterior and horizontal canal. So that's more likely also than, for example, right side, and which is where I was slightly more, skeptical than, but the right side posterior canal and then left side apogeotropic.
You, how confident are you with sitting tests rather than lying down like you do for the standard Dix Hallpike? You're flexing forward, backwards, that kind of those kind of tests done in the sitting position.
I think in terms of the actual, my personal preference is the old-fashioned maneuvers, the tried and tested ones, where we have the data, where we have years of experience of knowing what we're looking at. And the whole pike is not suitable for everyone. I appreciate that if you have neck restriction. So the only alternative I use for the whole pike is the Simont maneuver or the side lying maneuver to treat, for example, if they have significant neck restriction. But otherwise, the horizontal roll, relatively straightforward. Most patients can do that. They just need to be 30 degrees elevated. So apart from those, I don't really do any of the newer sort of supine, sitting up or sort of sitting up maneuvers.
Okay. What would be your global feel? Has there been any change in the treatment, or has new maneuvers been more effective over give it a 10-year window?
I think I'm probably the wrong person potentially because I don't necessarily always follow the new maneuvers. I'm quite old-fashioned, tried and tested. We know what works, we know what doesn't work. And if it's working, why change it? And I appreciate someone's always coming up with a newer maneuver of some sort. And yes, in resistant cases, I might then, let's say, go ahead and try some of the newer maneuvers. But by and large, let's say something like the Guffoni has worked wonderfully for treatment of horizontal canal. Barbecue roll has worked perfectly. And a whole pike and Simont maneuvers all work, great for posterior canal. Anterior canal tends to be, I think, well, a bit more newer in terms of its treatment, but similarly, lots of people have different opinions on anterior canal BPPV as to how much of it is actually present to a certain extent. But going back to sort of your question, I think none of the newer maneuvers are necessarily going to be life-changing immediately, as far as I'm concerned. I think the main evidence that's come out at this point is the link between low vitamin D or vitamin D levels and recurrent BPPV. I think there's strong evidence for that. So that's one practice I have changed and institute, pretty much telling all my patients where I see them again for BPPV, especially in the UK, to consider supplementation. And anecdotally, we do see a reduced number of recurrences on the ones we're taking. Well,
So,
hopefully we'll publish that.
one more question. You see a lot of case reports now about short arm cupidolithiasis and canal jam and stuff like that.
Yeah.
Your take.
I can see where people are sort of academically exercising their I guess where this particle might be. Has it changed what I do clinically? So I'm a clinician. The way I think about it is not so much more of as an academic, but as a clinician. And as a clinician, practically, has it changed anything? The answer is no. Sometimes, the main difference I find is that trying to differentiate between cupulolithiasis and canalolithiasis. But otherwise, as long as you give it you pick the right side, you know which to pick the right maneuver, do the right treatment, all roads lead to Rome, and the end result seems to be similar. At least that's my take on it. And so I haven't really academically exercised so much as to exactly where you might find the orthogonia. Sometimes you might need a bit more of a buzz or a bit more of a shake. That's about the only.
Do you do vestibular? Do you do vibratory maneuvers to vibratory whatever? You
I
know
do.
what I mean?
And I do. So routinely, as practice, you can do the tapping, you can do shaking of the patient. Adolfo Bronstein, always used to give the patient a good shake. You don't need to invest in anything too expensive, like the actual medical grade vibration devices are. We're looking, I think, more than 1 lakh rupees, which is pointless. I think I bought a massage gun from Amazon or whichever Chinese brand you get, which a small one, which you can use to just give that a bit of a buzz, if
And
especially in
when do you give that? Before the maneuver, after the maneuver?
during the maneuver. During the maneuver,
So while you're doing it, you're creating a vibration.
correct. So to loosen it and to then subsequently get it
So
moving.
now I'd request Mohammed, would you like to clarify any doubts or questions from Dr. Arun?
Yes, sir. For apogeotropic, sir, uh, can we how can we do the head shaking manual? How any difference compared to other manuals like Apiani? We're doing
When
head shaking manual.
when you say head shake on its own, no, I think you're going to need a repositioning maneuver. And there's, you're trying to get this from the far end of the canal all the way around and out. So it's going to, particularly apogeotropic, it's a lot trickier. But I do combine, and patients hate me for this, head shaking followed by the maneuver. So that's one technique you can use, or vibration, or tapping or those kind of things. But generally speaking, combining those two, so do the head shake, then do the maneuver, then that it tends to work a bit better.
Thanks.
Pleasure.
Go ahead. You can pick his brains. Don't let Arun go that easy, okay?
So what
Yes.
about Lee manual, sir? Have you done? Actually, I have done for I think 3 or 4 patients. Lee manual for posterior canal.
I didn't get the question myself.
Is
What
it
about Lee
Arun?
manual, sir? For
It's called a
posterior canal.
Lee maneuver.
Yeah. So
What was
actually, I
that?
have done for 3 or 4 patients. So they felt better after the manual.
Would you spell that? I missed that word again.
L-I.
Lee. Okay.
Lee
It's a,
manual. For posterior canal.
it's a Chinese person or that kind of a name? Lee.
That I'm not sure.
Yeah, I believe so.
Yeah.
I think I'm not sure where he was based. Sorry, apologies. He might be based abroad, but ultimately, yes, it's a Chinese origin person.
That name sounded Lee. I haven't heard of that. Yeah.
And there is a maneuver called the Lee maneuver. The question is, have I needed to use it? And the answer is no. Frankly, only because with the right maneuvers, with the right selection of what we already have, we can treat the majority of our patients. I haven't seen a particular need to utilize that Lee maneuver or any other maneuver on my patients. As we were talking about some of these newer maneuvers, why? If the tried and tested works, then I'm sticking to it.
Okay, fair enough. Mohammed, take your opportunity. This is your time to really get him, and then I'm going to open this out to the audience.
Sir, another case, sir. So we had a lady. So not lady, she's a girl. She's a 19-year-old girl. So she came to the department. So at the beginning, she had more like the lightheadedness, that vomiting. She was very tired. So that time, without BNG, I had done the testing, Ixorpac and Ixorpac. So that time, the nystagmus was very quite high. So she had vomited. So we didn't went for the manuals. That time our doctor said we'll give the stem till, and after 2 or 3 days we'll schedule the VNG. So that time she came, the vomiting, all things are gone. It was okay. But when I have done the Dixolpic test, the nystagmus is not fatigue, sir. It is continuously beating. But I asked her, do you feel any symptoms? Not any, sir. But the nystagmus is not fatigue. More than 5 minutes I have waited. I thought it will get last. But
And she was asymptomatic, was she?
So there is no, no, sir, no symptoms, sir. But the nystagmus was.
No,
Then I
so
have
she
done
was.
every.
Yeah, that does happen. It happens particularly just on that particular history. Obviously, you want to rule out anything more nasty, like like tumors and other strokes, etc. So you want to rule out anything nasty. But vestibular migraine might be a candidate in that kind of patient. And I have seen one or two cases where I remember quite clearly. I'm sitting there asking the patient, "Well, are you feeling dizzy?" And the answer was no. And you can see the nystagmus, going off. Equally, though, sometimes they become so desensitized to the BPPV that once you've treated their main sort of, I guess, posterior canal BPV or whatever it is, they have residual nystagmus coming from arising from some of the other canals, and they just don't feel it so much, as in the brain's recalibrated to filter out some of the lower level nystagmus. So I think those are the two main options I would think of in that particular patient.
Yeah, even our daughter also say the same thing. It will be migraine. So I have the examination after the testing. I have done the subjective test. So the Romberg was positive, Fukuda was positive, even the Tandem was positive. So I thought it was central. So we are sent it for MRI. The MRI was normal.
Good.
MRI was normal. So
Okay.
the
I think that's a
migraine.
sensible thing to do. You don't want to miss those nasty ones. No, because that's the one that will come and bite you. You want to make sure you play on the safest side, because it is not low percentage. Up to, in the acute vertigo scenarios, 15 up to 15%, 20% of cases have been shown to have potentially a small infarct affecting the cerebellum, mostly the cerebellum, let's say, not even so much the brainstem. But otherwise, I think it is something which is in keeping with vestibular migraine, but that's a diagnosis of exclusion. There are also many other causes, things like spinocerebellar ataxia, for example, degenerative conditions, all those neurological things, which may then be the, really the bottom line diagnosis once you start exploring things, if things don't settle. But I would think vestibular migraine is the first thing you want to treat. Great.
I think there would be a case for a repeat, for a follow-up, a tight follow-up, and maybe a repeat MRI down the road.
Absolutely.
Because one negative MRI, many times we have seen things showing up later on. But the main thing, forget about the MRI, keep a tight follow-up. Don't let this patient go. Because in India, especially, when they slip through the cracks, if they're not symptomatically better, they go to another doctor. And
Yeah,
his chart starts from day one because he doesn't have access to your records. And that way, Arun, you stay in a slightly blessed place because you can actually keep a tab on your patients.
Oh, well, yes and no. I mean, I wouldn't. As you may or may not be aware, none of the NHS hospitals, by and large, talk to each other. It's just starting to happen, the integration, and of course, in the private sector, no one talks to each other. So then, we kind of empower the patient. I think empowering the patient is the one thing which I do all the time. You have the records. You keep track of your health condition. These things can be serious. So make sure even if you go somewhere else, make sure you ask the right questions, make sure you have the right information.
So maybe a suggestion to you, Mohammed, whatever you have studied in your training period of disposing a patient, unlearn that and go to actually treating, talking, engaging with the patient. I mean, I'm not advising you. I'm just going back to my experience. In my training period, we were not treating, we were disposing. So I think now you should get that disposal out of the way and start treating, engaging, and actually convincing. All those things, they play a role in your, especially if you're in a quasi-private place.
sure.
So sorry for that, Gyan. I know it's Friday, and maybe it's a Thursday, heading towards your Friday anyway. So uh, I don't know if any of the audience is awake, but if they are, they're welcome to pitch in and ask questions. If there's anybody in the audience, he could just show his hands and unmute and speak.
Hi, my name is Gauri.
Go on, Gauri.
Hi. So, can I ask a doubt which is
Please.
unrelated to this specific case?
No, go ahead. Go ahead. Go ahead. No.
Yeah.
Arun
So,
is here. We caught him. We got him till he gets off the mic. Yeah.
yeah. So, like he had mentioned about canal jam. So recently, like I have seen a patient where all the positional test, McClure-Pegnini and Dixolpike, both sides, the nystagmus was in a single direction. So it was towards right side for all the test. It was the nystagmus direction was not changing depending upon the position. So does that indicate canal jam, or uh, like how is canal jam manifested in a patient? Like what would be the findings specifically? So we had suspected canal jam in this case. So is that right, or should I have tried something else also?
Arun, it's yours.
So, firstly, the history. I think treat the patient, not just the numbers from the diagnostic tests or even just the clinical examination. Were they symptomatic just to one particular side, or were they symptomatic to all sides? I think that'd be the first question I would ask. Number two, whilst we're talking about the canal jam and right beating nystagmus, etc., in all directions, as far as I'm concerned, I would treat that, unless you're an expert, as a red flag. And if it's a red flag, if you consider it as a red flag, you want to exclude all of the other, because it's not a typical pattern of nystagmus. It's just constant right beating nystagmus.
Yes.
Now, of course, that can happen in the acute phase. So are they acutely vertiginous, for example, or is it more a chronic patient?
No, like he just had 2 episodes of vertigo. And what happened was after the first episode, which like he was admitted in the casualty because he had vomited and he was too nauseous. They did epi,
Yeah.
and then on the second day he came to us. And then what happened was I did the whole VNG, and after the final test, which was Dixolpide left, he felt better. Like I didn't had to treat him specifically. The moment I completed the whole VNG procedure, he was completely all right. So again, yeah, after 1 week again, I called him back and repeated VNG. Then again the findings were same, but then the frequency and that intensity of the nystagmus had become lesser, and he was also reporting that he was better since the past 1 week. So yeah, so I
And
couldn't. Huh.
fine. So this was an acutely dizzy patient who had, and did they have resting nystagmus on the VNG?
Uh, no, I think it was subsiding after a period of time when I was recording.
No, he's asking if it was there at rest, straight gaze.
At rest, yeah, at rest, in like when the vision without fixation, yes, it was there, but with fixation, it wasn't.
Okay, so it sounds potentially that this might be in keeping with an acute inner ear dysfunction, like acute vestibular neuritis, possibly. Is that
Yeah.
potential?
Yes.
Could it be a right vestibular
Neurite, yeah,
neuritis?
yeah, there is a possibility, yes.
Because
Yeah,
then
so
that
that
would explain the findings, no?
and
Okay.
and it'll be there when you do the positional testing as well.
Sorry.
In an acute phase, sir is
Huh.
saying, you can have it during positional phase because anyway he has a resting nystagmus. It gets aggravated.
Oh, yes. Okay, okay.
Yeah.
So, there's that saying that if you diagnose rare conditions, you'll be rarely right. So maybe you should look at the commoner things. I assume that's what you are saying, Arun.
Correct. And I think, marrying the history to, because, I don't think I did anything too special there. It was just marrying the history and the potential, presentation to the then examination and nystagmographic findings. So that's the keys, I guess, take home message, really.
Which could explain the persistence of the nystagmus in the VNG also, because it takes some time to settle.
Absolutely. And then it's improved over time when the next time you saw them.
Did you do an audiology estimation? Hearing test was done, Gauri?
Yes, hearing was normal. He didn't have any complaints related to hearing.
Okay. And which state are you from? Where are you from
Ke-
actually?
Kerala.
Kerala. Do you
Yeah.
have a high COVID resurgence there?
Not much now. For now, it is under control, I feel. Yeah.
Because COVID is making its way back, and that led to a
Huh.
lot of protein manifestations actually, Arun. I don't know about you all in England, but COVID in a
Interesting.
different form, it's been
Yeah.
the virus
And
has
is
been
that
identified.
recently?
Yeah.
Was that recently? No,
Off late.
because
Yeah.
only today I read in the news that there's this a virus traveling through the Middle East at this point. So I'm sure it will be hitting the UK soon. Or it's probably here already, I dare say. But these things travel fast, don't they? But it sounds like yes, there's another variant in the move.
Though I think there are a few papers of COVID and vestibular lesions, right? There are.
It is high up on the list of so it's around middle part, let's say. No, maybe not right up there, not low down either. The
Right.
audiovestibular manifestations of COVID infection are there. And I remember reading a paper a while ago where they didn't manage to isolate COVID, I guess, remnants or RNA, whatever it is, from the inner ear fluid. So it's from the endolymph, etc. So we do know that it does live within or attack the inner ear in some form or another. And it can be part of the long COVID spectrum of symptoms.
Okay, so I think we must call halt. If there is no more questions, and I assume they won't be right now. And I don't know how to thank you, Arun. You're a pillar of strength,
Pleasure. It's a pleasure
and
as always.
always a pleasure to see you. And I think meeting up is now something which I must actively plan, because I think if you don't plan, nothing
Definitely.
happens.
Definitely. I'm looking forward to it.
Thank you, Mohammed. I think I'm very impressed, and it might
Thanks, sir.
interest you to know I also come from Palakkad. So, that extent, it's good to know that there are people there whom I can refer my cases to if they come filter
Sure,
through
sir.
to
Sure,
me.
sir.
So, thank you, Mohammed. Congratulations. I think keep
Thanks.
up the good work. Try
Yeah.
try to publish these cases.
Yes, sir. I'm
Right?
planning to do, sir.
Yeah, do that. Present
Thank
it
you.
and
Thank you, sir.
publish. Not at all.
Thank you, Arun, sir. So,
Thank you,
It's a
Arun.
pleasure. Take care. Take care,
Yeah.
man.
Thank you, Gauri.
Well,
Thank you very much.
and speak to you soon, Dr.
Yeah.
Thank you.
Jai Hind, as they say nowadays.
Indeed. Take care.
Bye. Bye.